Recording again. Welcome back. We're now going to move into a phase of the meeting where we will do further deliberation and have the Midwest CEPAC vote on specific questions related to comparative clinical effectiveness and value. So why don't we go ahead and see the first voting question. All right. So we're going to ask this about each of the three treatments, molnupiravir, Paxlovid, and fluvoxamine. The first one will be on molnupiravir. And the question is framed in this way. Given the currently available evidence, is the evidence adequate to demonstrate that the net health benefit of molnupiravir is superior to that provided by symptomatic care alone? So I'd like to start by asking if Kai can briefly summarize again the key evidence and point to the tables in the evidence summary for the CEPAC that kind of reflects the information that they should be thinking about most in their heads as they consider this vote. Kai?
Yes, thank you, Steve. So let's see. So table 4 provides the clinical evidence for these treatments of interest for its key trial endpoints. And table 5 provides the adverse events data. So just recall that molnupiravir reduced the risk of COVID-19 related hospitalization and all-cause death, which was the primary outcome, with a relative risk reduction of approximately 30%. We had discussed in the trial itself, there was not a signal of serious adverse events in terms of greatly above the rate that we saw in placebo. However, as presented previously, we discussed a number of potential concerns with regards to safety, with regards to carcinogenicity, teratogenicity, incorporation into growing cartilage and bone, as well as viral mutation. We believe that according to the FDA EUA label, which restricts it to adults age 18 and over, and not recommended for folks who are pregnant or breastfeeding, and who have no additional alternatives in terms of COVID-19 approved FDA EUA treatments and the limited course therapy, that much of this risk can be mitigated. However, given these concerns, we do give it a C+ rating, which is of net health benefit of null to moderate, given these concerns.
All right, great. So actually, before we even jump into comments or questions from the CEPAC, Adarsh, I'd like to ask you a question. So just reflecting again, on the data and the way that it's been interpreted by others, when the FDA Advisory Committee looked at this, it was a pretty close vote, as I'm sure you know. It was 13-10. And the reports on kind of what they were thinking as they were interviewed, the members of that AdCom were interviewed afterwards. There was a lot of talk about the risks and about their concerns about that. There was some talk about confusion about why the percent of the relative reduction seemed to drop so precipitously in the second half of the trial. But when you step back, you see a 30% reduction in hospitalization or death. You see, the death is something that certainly Merck made a public comment about at our meeting. That stands out in some people's minds. So what do you think, if you were advising the CEPAC to look at kind of these different perspectives, the good and the bad, if you will, of the evidence base here, what would you emphasize from your perspective that they should think about?
And Steve, I don't know, my perspective is as a clinician and as a guideline writer, I don't know if it's slightly different from yours. And I still struggle with, we always look at each of these individually. But again, in the totality of the thing, what are my options? We don't have any relative comparisons of these agents. So the thought experiment, at least I do myself, is like, what existed, right? I think only molnupiravir was the only drug. Then my perspective would have been different. Or another thought experiment, I think, what if the results actually did not drop, right? If the effect size remained the same and we don't have these putative possible mutagenesis and teratogenicity effects. All these are the unknowns. And not just me, when I talk to other clinicians and my own guideline panel, and I had the opportunity to actually talk to the FDA, like people who are on the committee for molnupiravir, it is the uncomfort or discomfort about the unknowns that made them weigh molnupiravir less than other therapies. Paxlovid looks better. And I hate to look at it in isolation, but I also have IV remdesivir. Logistical issues aside, if I can use that in that same population. And monoclonal antibodies, again, they might make a comeback. So that's part of the reason my enthusiasm was molnupiravir. Like if I can put a hierarchy of things which much lower, because I have other options which have better clinical efficacy and at least known safety profile rather than an unknown safety profile. I hope that answers the question, or maybe that even adds more confusion, Steve.
Well, no, actually, I was hoping that you would further muddy the water before the CEPAC got to ask their own questions, but I think you shared an important perspective. So let me open up to questions. I see Jill, then Ingva. So Jill, please go ahead.
Okay, so thank you for that, Adarsh. So my question, even without, because I keep going back to this, I keep getting confused about it. So even if I'm not comparing, if I had a patient in front of me and I was trying to pick one versus the other, even if I only had molnupiravir, the question is, does it have adequate evidence currently to support versus supportive care alone? And I feel the need to justify saying, but in an unvaccinated population, would the absolute difference between those two groups, placebo and molnupiravir, be 3%? And I don't think that it would. And so that's what catches me up on this question.
Jill, you bring up an excellent point. Right? Again, we're not dealing with Ebola in Central Africa with a 90% mortality. I hate to put that perspective. All the complication rates, even in the high risk, are in single digits, right? I'm not talking about like critically ill patients. So we forget the choice of no treatment or supportive care, and also assessing the risk of a severe complication in our patient. In a post-vaccine variant world, what are the risks? I think regardless of what therapies you're considering, I think people forget that. And you bring up a great point. I think, will my patient benefit from any drug, let alone molnupiravir? That is a fundamental question every clinician, every policymaker should answer before we ask yourself which therapy, correct?
Good comment and good question. Ingva, please go ahead.
Yeah, Steve and Reem, I just wanted to make sure that I completely understand the question, because, you know, we are not right now voting on at the time of December 21st when the EUA was done. We are voting right now, April 12th, right? Not an upcoming more severe virus. We are April 12th, what we know right now, what it looks like. Would I think at this point, then I have a patient in front of me that will be given molnupiravir, will it have a net health benefit?
Correct.
Thank you.
And just to even add on to that, so we're not asking you to, again, to create a clinical guideline for what should be used first. I mean, it really is almost exactly as Ingva said, trying to look at the evidence as we have it for today's decision about whether the evidence is adequate, that it provides a net health benefit over symptomatic care. And obviously that's an average over different types of patients, but that's something that you guys are used to doing. Ed, you're back. Thank you. I know you're having some internet challenges. You might not have heard my question, which was kind of, why did the FDA AdCom have such a hard time with molnupiravir? We're seeing 30% reductions in hospitalization or death. We've heard about the risks, and we know that in the interviews of the AdCom members and the comments today, that the risks are still part, certainly, of people's thinking about the net health benefit. Do you have anything that you'd like to add in terms of how you think the CEPAC should think through the data? And that could include your views on the inpatient trials of molnupiravir, or the way that the data, again, shifted between the interim and the final ITT results. What would you want the CEPAC to think about as they take this vote?
Okay, so I have written, I had a letter to the editor at New England on this. There's other people have written. There was a nice paper by in American Journal of Tropical Medicine and Hygiene. stating that the interim analysis, the first portion of the molnupiravir study, compared to the second half of the study, it is statistically implausible to come from the same trial. And so I have done a long time of working in clinical trials. I think something went very wrong at the country level. And I do get the impression Merck is well aware of this and also doesn't quite understand what went wrong at the country level. So you have the data that went up to approximately 50% of the trial recruited, and it gave a 50% reduction, if I recall correctly. And then the second half, where they completed the trial, actually favored placebo. And if you look at them as two separate trials, you find out that statistically, they're not, you would not put them together. When you do put them together, you end up with a 90%, or sorry, a 30% relative risk reduction with an upper confidence interval that's about 1.01. So, you know, all that one can be said is, what one can say, I think, is that there needs to be realistic exploration of what went on there. Having run trials for a long time and being familiar with, you know, problems at different sites, I am suspicious that there were site problems at some locations that there hasn't been enough discussion of just yet.
Okay. I'll just note briefly, and I know we don't have this in a situation in which Merck can quickly counterpoint or you know, kind of pose other possibilities, but their public statement back in November, at least, around the time of the FDA AdCom, they did highlight differences in the male-female split in the patients recruited in the second half. The age was different. Some of the countries were obviously different. There was more diabetes in the second half. So they were trying to explore different clinical things that could have potentially differed in a way that could explain some of this. But I just wanted the CEPAC to kind of hear both sides, if you will, of this issue, because I know you guys have been thinking about it anyway. Don, why don't you go ahead?
Yeah, quickly, it sparked a question that I'd been thinking about relative to whether we should be taking a US perspective or a global perspective, or it doesn't matter.
I think it's best if you take a US perspective here. And if you want, you can say more about why you think that would differ in terms of interpreting the clinical data, but because it's almost more relevant for the modeling and for the value than for the clinical data, but I'll leave that as it is. Anybody, so before we take a vote on this one, if there are no other questions that you guys would like to pose of Dr. Mills or Dr. Bimraj or of our patient expert, I'd be curious, since there was a split vote at the FDA Advisory Committee, does anybody want to say that they would vote a particular way and want to provide their justification as a way of having your peers hear your thinking before we take the formal vote? Anybody like to nominate themselves? Reem, go ahead.
Yeah, I think what Ed just mentioned, Steve, I know that in the report, the evidence was rated as a C+. I would just highlight that I do have more uncertainty overall than the C+, to be very honest. And with that, adding to that, what Ingvar mentioned, you know, a few minutes ago, where there's all these uncertainties about the potential harms. I'm not even sure with how the issues, the differences between the interim and the final analysis. It can't be, there's too much heterogeneity that I don't know what to believe. So I think overall, the truth is I can't really reconcile my thinking with the C+ even. That's how I'm thinking about it.
Okay. Rachel?
Yeah, I think here I just want to clarify, just for everyone so it's clear maybe about my thinking, that the wording of the question is not should the drug be available. It's not should the FDA have authorized this drug. It's is the evidence adequate to demonstrate a net health benefit here? And that's a separate question. And for many of the things that have been discussed, we might reasonably have more uncertainty but think the drug should be available.
Correct. Kurt, you had your hand up. Did you want to follow through or you?
Yeah, I was just going to add on to Reem's comments, and I think they're very well articulated. If we had another trial or some other evidence, I would feel more comfortable that maybe the trial's methodology or the nuances that led to some different results that could maybe be overcome. But I'm just having a tough time with the one trial and a lot of questions about it.
Okay. Now, I admit that this is, I'm trying hard not to lead the witness, if you will, but I'm just pointing out how difficult this is, because you could look at this question and you could, again, as you have already said, this is not a question about whether it should be used first, last, or otherwise. It's a question about the evidence, but it's impossible to disentangle that from the context. So again, the EUA stipulates that this should be available for patients who do not have another treatment option. So you could consider the patients who are not able to, for whatever reason, take Paxlovid, let's say. And for that set of patients, do you think the evidence is adequate to say that molnupiravir provides something better than supportive care? That would not be an unreasonable way to interpret the context. If you wish to interpret it differently, that you really don't want to think of other treatments being around and you really just want to think of it as a level of certainty with a net health benefit for all eligible patients with mild to moderate COVID, not those who can't take other treatments, that's your prerogative. But I just want you to kind of be clear in your own minds. We are not telling you exactly how to frame that, because I think it's fair for people to have a different opinion about the best way to vote on the evidence today. So I was trying to be clear about why I think this is a really hard voting question for you. Any other questions or comments before we do take a vote? Okay, Monica, why don't we go ahead and put the voting question back up? All right, please go ahead and enter your votes. A is yes, the evidence is adequate, and B is no, the evidence is not adequate. And we have 13 votes, so I'm just waiting for one more at this stage. Okay, why don't we see the results? Okay, 11 no and 2 yes. All right, let's go on to the next voting question, which is the same frame, but about Paxlovid. So I'm not going to read the question again to you. Same questions about Paxlovid. Kai, can you again quickly debrief them on the evidence and the evidence summary?
Yes, same tables are the ones that I'm referring to. But in essence, the point estimate for Paxlovid versus placebo in the primary outcome of hospitalization or death of any cause shows an 88% relative risk reduction. And that's statistically significant. In the trial, there was low rates of adverse events and low discontinuation rates as well. This is from one trial, as with the other treatments of interest. And the known issues, which we've already discussed, is this issue with many known drug-drug interactions with ritonavir. Some of them are likely to be important, given that these drugs include anticoagulants, antiplatelets, anticonvulsants, and immunosuppressants and other important drugs.
Okay. Anybody have any questions about the evidence base as it exists for Paxlovid? All right. I wonder if we talked ourselves out on molnupiravir, but there might be some others. Kurt, go ahead.
Yeah, I think the evidence about Paxlovid is stronger than the previous drug. Kind of an open-ended question that's probably unanswerable is, I wonder why other protease inhibitors didn't show efficacy against COVID.
Oh, I bet Adarsh would love to answer that question.
No, Kurt, again, for me, we think of very black and white mechanistically, right? Again, protease inhibitors of which viruses, like previous protease inhibitors which have used, which lopinavir, ritonavir, were unique with at least in vitro avidity to retroviruses. What is the affinity to the receptor among RNA viruses? I think that is but at the end of the day, I'm also going to say that is purely a mechanistic speculation. I think the proof of the pudding lies in empirical data, which shows patient-reported outcomes get better. I think for future like molecule therapy design, that's a good question. But I think the RNA proteases might be uniquely different from the other viruses, especially for respiratory viruses. And maybe that's one of the speculative reasons why it worked better.
Okay,
Okay,
thanks.
thanks.
Don, go ahead.
I'll let Eric go first.
Okay.
So I was just going to make the point that when I'm considering this question, I am considering it on the possibility that you could find a patient who might be willing to take it, who wouldn't have contraindications or drug-drug interactions, right? So I happen to believe that the universe of possible patients that this particular treatment will be acceptable for is small, right? And I think that makes it tricky, but I am trying to frame my answer on this question around the idea of, based on the evidence that we have, for a patient that's willing to take it, who, you know, wouldn't be at risk, at significant risk for a drug-drug interaction or contraindication, that's who I'm applying it to. So I feel like that's consistent with, I'm kind of putting that out there to the group to say, like, that's how I'm thinking about it. And if anybody, if I need a correction or a redirection on that, I welcome it from the team.
I think, yeah, I guess my only comment is I would encourage you to think about the evidence a little bit more than the real world uptake in this case, because there could be lots of reasons that it's not flying off the shelf or is in certain areas. But I would, again, let a clinician who's currently treating and prescribing this medication. So Adarsh, again, I mean, you were kind of asked earlier, all comers with mild to moderate COVID, what % of them would be ineligible to even take this? Your comment was that in general, it's not a contraindication, full stop. It's more something you just have to consider and do individual kind of patient shared decision-making. But anything else you'd like to say to the general question about how this is viewed clinically in terms of the patients who can and can't take it?
Steve, again, for me, like I said, any of the therapies, not just these 3 therapies, there are a lot of exclusion criteria in the trials. And as a clinician, when I'm using that drug, I have to use my judgment call. For Paxlovid, it is drug interactions. For at least for baricitinib and other stuff, I'm going outside the contracts where immunocompromised states. None of that, I think, is an absolute contraindication. Even if you have to use your judgment, I believe that should be left to the clinician, right? Rather than any panel or policy deciding the applicability to a unique situation. Because who will benefit, I think it'll be impossible for a panel or us sitting over here to figure that out, and that has to be a clinician judgment.
Right. And again, we are not trying to create a guideline. That's your job, Adarsh. So again, back to Eric, again, I would think about the evidence in a slightly pure kind of isolated fashion almost in this.
That's what I'm trying. I mean, that's how I'm trying to not be influenced by the other side, right? So,
yes. Okay, good. Don, go ahead.
I'm not being influenced by it, I should say.
All right, good. Don, go ahead.
Sure, I'm sort of harkening back to the Jill Johnson question and looking at it through the lens of vaccination status relative to whether I would be more certain for unvaccinated versus vaccinated. I'm not good enough to tell you the methodologic or analytic differences between those 2 populations with respect to symptomatic treatment, symptomatic progression, but certainly both classes of people having symptoms would obviously spark my interest in treating, but I think I'd be more inclined to treat with the unvaccinated as opposed to the vaccinated, but that's just my guess.
So I'm tempted to show you the ICER analytics platform where I could actually show you how in the modeling we can change that percent of the population that is vaccinated that presents with mild to moderate COVID, because it's easy to do, if you will, in a model. But that being said, what's assumed is a lower, based on data, is a lower risk of hospitalization for people who are vaccinated. And yet the relative benefit of any of these drugs applied to whatever that risk is, we assume is not different, because we have no data to suggest that the relative risk changes, even if if you will, the background risk lowers or increases over time. So I would still think of the relative risk as applying to it. But if there are side effects, that's when you really do have to worry about, if you're making a net health benefit, you really do need to know in your own mind what that background risk is, if you're willing to accept clinical risks to get the clinical benefit based on the relative risk. Hope I'm making sense.
Yep, thank
All
you.
right. Okay, any other questions? I'm seeing none. Why don't we go ahead and vote on Paxlovid's question? Okay, again, given the currently available evidence, is it adequate to demonstrate the net health benefit of treatment with Paxlovid is superior to symptomatic care alone? A is yes, and B is no. Okay, we can look at the results. Okay, 13 yes, 0 no. Okay, let's move on to fluvoxamine. All right, same question, and pitching it back to Kai again to summarize the evidence and the ICER rating for us.
All right, so similar tables. Essentially, the point estimate for fluvoxamine is a 30% relative risk reduction in the primary outcome, but this primary outcome definition is a little bit different for fluvoxamine, in that includes individuals who were retained at an emergency setting for more than 6 hours or hospitalized. There is, in the trial itself, the drug was fairly tolerable, but there was a decent amount of folks who discontinued from treatment, both in the intervention and in the control arms. There is also a lack of statistically significant effect on a number of secondary outcomes in terms of viral clearance, time to hospitalization, hospital length of stay, death, or mechanical ventilation. That represents some of the uncertainties regarding this drug. And hence, as with molnupiravir, we rate this as a C+, meaning that it has a small or null / comparable or small net health benefit. Again, currently, fluvoxamine does not have an emergency use authorization for our population of interest, unlike molnupiravir and Paxlovid. It is approved already for, and it's generic for OCD.
Can you say just a little bit more about whether the C+ here was due to uncertainty around the benefit or harms being a part of the equation, if you will? What was the balance that got
primarily
a C+?
Primarily uncertainty with regards to the benefit, right? So a couple of things. The relative risk reduction is similar to molnupiravir, although in absolute terms, like absolute risk reduction, just to be transparent and a little bit more detailed, it's actually similar between fluvoxamine and Paxlovid because of the higher rate of hospitalization in the placebo and the intervention arm at the time in which the together fluvoxamine trial was conducted in Brazil. So there's that, and then there's the composite primary outcome, which is different, and there may be questions about its applicability to the U.S. setting, and then the secondary outcomes as well, right? Broken down. Supporting this consideration are some judgments from both IDSA as well as NIH. IDSA has a ranking of these treatments, with Paxlovid having a preferred ranking, molnupiravir being an alternative, and fluvoxamine suggesting both for IDSA and for NIH, suggesting that there is insufficient evidence regarding these treatments. So primarily around efficacy.
All right. Okay, Kurt, go ahead.
So maybe this is my pharmacist brain thinking, maybe an overdrive, but with Paxlovid, we know it's an antiviral. Molnupiravir, we know it's antiviral. Fluvoxamine is not really an antiviral. might have effects, but for me, it's hard to kind of make that connection between this drug and having a demonstrable effect. And I understand, what the trial is showing, but I don't know if you want to comment about that mechanism of action that I'm just troubled with.
Yeah, I can elaborate.
Let's let Ed do that part. Obviously, he has. You can call it a vested interest, or you can call it someone with deep experience. But there was a reason that fluvoxamine was put into this trial. What was it? And why was the mechanism of action thought to be potentially helpful?
Okay, thanks, Steve. Thanks, Kurt. The mechanism of action in this trial is believed to be anti-inflammatory and not antiviral. Nobody claims that fluvoxamine is an antiviral. Keep in mind that the progress of this disease is believed to be that you have a high viremia followed by an inflammatory response, etc. And that's where we believe that the effect comes from. I think it's important, 2 or 3 clarifications on what Kai had said. When you look at the same composite outcome as Paxlovid and molnupiravir, it shows the same treatment effect. So when you use the greater than 24 hours in an emergency setting or hospitalization, it's the same. There were 2 meta-analyses published last week supporting this, one in JAMA Network Open, the other one in American Journal of Tropical Medicine Hygiene. There's a new trial we've recently completed in Brazil, indicating the same thing. Some of the concerns with regards to tolerability are actually a little bit more complicated than assuming that people can't tolerate it. For those of you who've had COVID, myself included, it probably didn't last 10 days symptomatically for you. And yet 10 days was the course of administration of the drug. And so what we believe to be the case for non-adherence is people just stop taking it when they feel better. And so we had 20% of the population were not taking it at day 10. And we believe that that's because 10 days of treatment is more difficult to take than 5 days, for example.
Okay, thank you. Don?
Now, this is back to my US question, Steve. There were no US enrollees. So how could we reconcile, and I think it was Ed mentioned some of the country problems. I don't know what those are, but how do we think about this treatment, knowing that we don't have data inside the US, at least for this trial?
Well, I'll answer briefly, and then Ed may want to pitch in again. I mean, unless we think that there are truly kind of pathophysiological reasons that the virus behaves differently in human beings and other countries, you would think that a well-conducted randomized trial should show the same relative effectiveness wherever it's done. You might have a different background rate of hospitalization given the healthcare system differences, other aspects of what variants were around at that point in time and all that kind of thing. But if it's a randomized trial and we don't foresee any specific differences in the way that it, I guess, interacts with human beings in different areas, I think it would be viewed as generally fairly generalizable. Ed, anything else you'd like to add?
Just that there was a trial from the US, and that's why we did our trial. So there was a trial led out of Washington University in St. Louis, and that's they had a very positive effect. It was published in JAMA, and that was what led us to do a larger trial.
Thanks.
There you go. That was very effective for the Midwest CEPAC, many of whom are based in St. Louis. So that didn't have any impact whatsoever, I'm sure, on their thinking. Okay, good. Any other questions about the data on fluvoxamine? Okay, let's go ahead and vote. A, yes, the evidence is adequate. B, no, it is not. Okay. All right, 7 yes and 6 no. Okay, let's go ahead and move into the discussion of the potential other benefits. We are going to have 2 votes and then we'll have a discussion, and I'm gonna have to try to speed up a tiny bit. But basically, the first 2 votes are kind of contextual, or some people would call them ethical questions, again, about the priorities that society may wish to put on certain treatments for conditions based on the nature of the condition. And so the long preamble here says that when you're thinking about the overall long-term value for money, what is the relative priority that should be given to any effective treatment for COVID-19 based on a couple of contextual considerations about the condition? And the first is the acuity of need that we sense for the treatment of individual patients based on their short-term risk of death or progression to permanent disability. Now, this question is not specific to COVID-19. It's used to frame the issue broadly, especially related to conditions where it might be a high rate of short-term mortality for patients, and a treatment that provides even a short extension of life might be viewed as one that we would give extra priority to because of the acuity of the need given that short-term risk. So here again, you guys all have heard a lot about COVID in terms of what it's like, both for very severely affected patients. Here again, we're thinking about, in general, any COVID treatment and the way that COVID behaves. Do we think that society would give treatment priority very low or very high based on the acuity of the need given its short-term risks of death or progression to permanent disability? Does anybody have any questions? Reem, go ahead.
I have not necessarily a question, it's more like a comment. I think one important thing that we've all lived is that the answer to this question at the beginning of the pandemic is likely to be, I think, very different than the answer to this question today. And one missing piece of information that will help me have more certainty about my answer is truly what is going on with long COVID. And I don't think we have yet a very clear idea. Earlier studies talked about 20% of the population having long COVID. The type of disease we're dealing with now is very different than what we dealt with earlier, and so on. So just part of what I'm thinking about as I'm trying to address this. Thank you.
I understand. That's a good comment. Thank you. Aaron?
So the question says the relative priority that should be given. And when you were just speaking, you said, I couldn't understand whether you were asking us the relative priority that we think it should be given or the relative priority that we think society would give it.
In a sense, you're meant to reflect this group is supposed to reflect society's values as it relates to this aspect of the context in which we see any treatment for COVID-19.
So in other words, if let us just hypothetically say, well, I think it should be high priority, but I'm a cynical guy and I think society doesn't care. I should go with society and not me.
No, you should. You are you should put in your own thought on the relative priority that you would give it based on your understanding of this issue. Okay, you guys have been through this vote a fair number of times, so I'm going to move us through it without seeing any other hands. Let's go ahead and vote on that one. So A is very low priority, E is very high priority based on the acuity of need for treatment of individual patients based on their short-term risk of death and progression to permanent disability. All right. Okay, so we've got, as you can see, 2 low, 2 average, 7 high, and 2 very high. All right, let me go ahead and to the next contextual question, which is about the magnitude of the lifetime impact of COVID on individual patients of the condition being treated. I'm hearing Reem's comment ringing in my ears, obviously, and this is tough because you're asked on a kind of overall basis without a whole lot of information yet about long COVID. But based in general on the what's viewed as in many ways a general societal interest in having higher priority for treatments for conditions that rob patients of a large part of their overall health over their lifetime, do we think this condition represents something that is a very low priority up to a very high priority? Any questions or comments before the vote on this? Okay, go ahead and vote. All right. All right. Slightly more tilted towards the lower slightly. So we've got 3 low, 4 average, and 6 high. All right, great. Now let's go to the next slide, which actually is not a voting slide. It's to tee up what's probably going to end up being about 5 minutes of discussion. And this is a little bit different, but we took the prerogative in our special assessment here to basically stipulate that these treatments have important other potential benefits and some disadvantages that are specific to the treatments themselves. So let me just read these. One is that basically effective outpatient treatments for mild to moderate COVID may help reduce the population spread of COVID-19. You've heard that, not fluvoxamine perhaps, because it's not an antiviral, but the others could reduce the viral load and therefore the risk of infecting other people. And that's not something that you catch in a clinical trial, for instance. What's another potential benefit? Effective outpatient treatments may reduce the number of hospitalized patients enough to increase the capacity to treat non-COVID-19 related conditions more appropriately. We've heard a lot about hospital crunch and ICUs being full and having a hard time triaging patients appropriately. So clearly, if we can keep people out of the hospitals and particularly out of the ICUs, will be an important potential benefit of any effective outpatient treatment. They also may help us address the disparate burden of the pandemic in disadvantaged communities. We're going to return to these issues in the policy roundtable, but we've all been aware that the prevalence of COVID in disadvantaged lower income communities is higher, and therefore, if we have effective outpatient treatments and can get them where they need to go, this could help us address that disparate burden. We've got effective outpatient treatments may help provide psychological reassurance, allowing for broader opening of schools and workplaces. Some of you may feel that that's a big factor here or not, but it's a potential other benefit. Although again, the context continues to shift with the types of variants and where society is and in being willing, if you will, to have shutdowns be part of our toolbox. And then we just list 3 different disadvantages, if you will, or slight advantages. For molnupiravir and Paxlovid, we're just restating that they have some limitations in terms of which patients can easily take them. For fluvoxamine, it has a potential advantage, not right now perhaps, but ultimately where its mechanism of action is such that it could be combined in a certain way. Who knows if that will be the case, but it's at least a potential future benefit. And then we're open to any other specific benefits or disadvantages that people think should be noted in the final report. So we don't have a lot of time to talk about this, but we've got 3 hands up. So let me quickly go through those and we'll see what we can get done. Stacy?
Thanks, Steve. I just wanted to make a comment about the disparate burden and the disadvantaged communities piece, because I think anecdotally what I've heard, at least, or seen people saying on Twitter is, the people coming in and asking for some of these therapies are not the people who we think are most in need or would most benefit. They're people who are vaccinated and mild cases and advantaged populations. Whereas I think, when we are trying to think through the benefits, we know that the trials are in unvaccinated people who may have a larger proportion of disadvantaged people who are representing that group. The other thing that strikes me is with the lack of funding and lack of ability to get free testing, that it could actually drive more disparities. So having these treatments available may actually not be as much of an advantage for some of these communities. And then the process of getting, to a primary care physician to get the prescription and having all that work in the right time frame. So I think I would maybe kind of think about whether or not we actually do believe that it would reduce disparities instead of further drive disparities.
Stacy, I think we are going to talk a fair amount about some of the challenges of access in different communities during the roundtable. But I think your statement's very fair, and I think we should note in our report that despite the hope that this could help address what we know are the disparate burdens of this disease, it could in some ways offer an opportunity to make it worse if we don't somehow do it right. Reem, I'm just going to try and go pretty quickly. Reem, go ahead.
Yeah, I think the other point that I keep thinking about is having these treatments, while is really great as an option, I worry about sometimes a false sense of security among the community with forgetting some of the preventive health measure and public health measures that we know are effective, but that people just get the sense of security, well, I can get a treatment and forgo what is more equitable to everybody and so on. And I think that should be recognized. And this makes me worried because especially early in the pandemic, when we had no medications that are effective, people still convinced themselves of efficacy that didn't exist just to argue against public health measures. So point to note.
No, I think that's fair since we're using the word potential behind both benefit or disadvantage. I think it's fair to note for policymakers that there is always the risk that the thought that we have an effective treatment, as you said, could undermine other preventive measures. All right, good. Rachel?
I wanted to echo Stacy's comment and just note that the interaction of our testing, diagnosis, and treatment systems is really the potential bottleneck here. It may be not only that access to therapies varies based on ability to speak with a primary care physician or something like that, but also whether you can obtain a test in a timely fashion, you can afford a rapid test, any in the stores, etc., all of that. And so, as often do in some of our meetings, I agree that there's potential to exacerbate disparities.
Yeah, I don't think I've seen the term wild goose chase mentioned as often in the media as I have recently around people's efforts to try to link all these different pieces, seeing a doctor, getting a test, getting a treatment prescribed, picking it up. It's really quite an odyssey in lots of ways. Adarsh, please.
Yeah, I kind of echo both Stacy and Rachel's sentiment. I don't know what the scope of this document, but I'm hoping you guys can mention that these drugs work when access to care is early, diagnosis is early and given within 5 to 7 days, right? Paxlovid and molnupiravir, whatever data we have. So while you recommend a drug, I hope you can also emphasize about addressing the inequities to access and testing for these drugs.
Absolutely. We will make note of that, and it will again come up in our policy roundtable that you'll be part of. Okay, we're just going to again note that slide again. Do you mind putting it up again, Monica, just so people can see it before we move on? So we are going to have some additions and some comments to flesh out some of these further in the final report, and really thank you guys for your thoughtful comments. All right, let's move to the last set of votes, which is going to be, in a sense, asking you to integrate your thinking and the comments around clinical effectiveness, around these potential other benefits and disadvantages, around the other kind of social priorities, if you will, that we talked about in thinking about the long-term value for money. But a core part of this is also the cost effectiveness. So each of these questions is asking about an individual drug, obviously, and it's asking you to think about all this evidence. And your vote's going to be either low long-term value for money at current pricing, intermediate long-term value for money at current pricing, or high long-term value for money at current pricing. Now, I just wanted, as I mentioned, I wanted to give you a quick flavor for some of the uncertainty that's in the model and a way to explore it. So I'm going to share my screen now and just walk you through quickly through a way to think through some of this. And I believe you'll be able to, can you all see my screen now with these kind of bars and stuff? For those of you who haven't been on the ICER analytics platform, this is one half of it. This is what we call the interactive modeler side, and in which the backbone of the ICER economic model is put into the cloud, and end users can go in here and change anything from which treatment you're looking to. I'll change it right now to molnupiravir. And any change I make in these tabs will instantly update the findings of the cost effectiveness here on the right. Everything from the total costs to the qualities or equal value life years gained. I like to look at equal value life years, so we'll look at those. Hospitalizations, and in this case here, also the final, if you will, incremental cost effectiveness ratios. So what you see right now are the base case results. And I've got other things that I could change in here, but to be quick, I'm going to skip over to a couple of examples that you may want to think through. And you can ask me other questions if you want me to put different numbers in here. But here's one thing that's come up over and over again. What is the percent of the total cases that we're treating that occur among vaccinated individuals? Now, Mel told you that our latest data from the CDC suggests that around 29% are vaccinated. People who walk in with mild to moderate COVID, about 30% have been vaccinated. But we could change that assumption. What if it changes to 50%? Now, remember, if you're vaccinated, your risk for hospitalization is lower, so it's probably going to make the cost effectiveness look worse. And it does. The incremental cost effectiveness ratios, if you look down here on the right, they went from around 60 to 73,000. Now that's still well under 100,000 per equal value life gained or QALY. I could make it lower if you wanted to. Again, you can do anything you want to with this number or different numbers. You don't have to just enter one at a time. You can enter a lot of different assumptions here. But that's just to show you the relative robustness is one way to just frame the results. We can change this rate of hospitalization, the rate of vaccination and the relative risk of hospitalization we can change based on vaccination. We can change all the different clinical outcomes that we have estimates for about rates of hospitalization with different oxygen levels. So there are a lot of assumptions, if you will, or data points in the model that you can change. And then for you all there, you also may want to think about this background rate of hospitalization. So here, this is one of the key numbers. Hospitalization, if unvaccinated, and this means among those who are untreated. So 4.9% is our current estimate. Let's see what happens to these numbers if we assume that Omicron or whatever comes afterwards leads us to a lower rate of hospitalization. I'll put in 1.5%. Cost effectiveness gets worse. But even at only 1.5% hospitalization for molnupiravir, the numbers are still lower than 100,000 per QALY or equal value life year gained. On the other hand, if we have a new Delta or something where the hospitalization rates for folks go up, let's say it's 10%, the cost effectiveness is going to get
Sorry,
better.
Steve, that was the ED visit that changed.
Oh, I've changed that. Sorry about that. I changed the wrong one. ED visit was, what was the base case? Do you remember, Mel?
1.5. That's why it was confusing.
That's why I clicked on the wrong
Yep.
one. Sorry. And I was wondering why I didn't change that much. Okay. But if I change the baseline hospitalization, that's where you're going to see cost effectiveness get a lot better. So you can see these numbers move. I chose, not completely crazy numbers here, but just to show you also that I can make these changes and the numbers don't float that much around, they go lower and they go higher, but we're not talking about vast differences up above 100, 150,000 per QALY or equal value life year gained. So maybe given our time, I won't keep this up for long, but if anyone does have a very specific request, and it may be Don since he raised his hand, but if anybody would like to suggest a specific number that for their own purposes of understanding the value they would like to see played out for any of these treatments, be it molnupiravir or Paxlovid or what have you, I'm happy to do so. Don, go ahead.
Steve, mine was more a quick question to ask whether economic issues such as productivity loss, being at home isolated for whatever number of days from work gets factored in, or is this just healthcare? I need to be reminded.
Mel, do we have the modified societal in here yet? I can't remember.
This is just the setting right now selected is healthcare sector. And so this is focused on those direct medical care costs only.
But I can shift to societal. So here you go. Right. So actually I can click to the different perspective here. And again, you can track the numbers. I can always revert all the way back to the base case, but I'll leave it at societal on molnupiravir for right now. Okay, Adarsh, please.
Yeah, first of all, I say this is cool. I wish we could do something on the guidelines for clinical baseline risk for this. My question again, not all vaccinations are equal, right? Again, mRNA vaccines are different from J&J, and whether I got 2 or 3 boosters, at least based on in vitro data and some of the other data, that granularity, I don't know if it's in the model, probably not, but I'm just throwing it out there.
Mel, what would you say?
Yeah, that's a great question. That granularity is not necessarily in the model, but really what vaccination is doing to the model is the hospitalization rate. So you could override the vaccination assumptions and just change the hospitalization rates to be what's representative of accounting for all of that variation.
Thanks.
But here's the number where if you assume the vaccination itself is more or less effective at affecting that background rate, you would change this number here, this 0.04.
We just don't have
Okay.
estimates based on, say if you're boosted or not boosted, that kind of thing.
Right. It's true. We don't have that yet. Okay, let me stop sharing. I didn't want to spend too much time here, but again, I wanted to show you how you can explore some of these areas of uncertainty and the relative stability of the results within the zone of the base case findings in this situation. Okay, let's go back to the voting question. And I know you guys have done these kinds of votes before. We've talked through all the individual issues that you're now being asked to integrate. One thing that frequently comes up though in the questions to me at this stage is, what do we do with, if we said that we didn't think the evidence was adequate on the clinical effectiveness, what do we do in voting about the overall value? And I would tell you that, like everybody else, you have to factor that in your own way. If you feel that your uncertainty about the clinical effects means that it's going to be low value, no matter what else we tell you about the cost in relationship to the base case kind of clinical benefits, that's fine. If you have a different view of how you want to factor in that earlier vote, you are certainly able to do so. So there's no right or wrong way to specifically take that earlier vote and decide how to vote now. Okay, I'm not seeing any other hands or questions, and we are a little bit pressed for time. So why don't we go ahead and take a vote on this one? Again, between A for low long-term value, B intermediate, and C high for molnupiravir. Okay. All right, we've got 8 low value, 5 intermediate. All right, for the sake of time, I think we're going to go ahead to the next long-term value for money question, Paxlovid. Again, I'm not sure we'll need further discussion. If anybody wants to probe a specific aspect of how the modeling was done around the cost effectiveness, I can share screen again and do so. But I'll give you a second if nobody raises their hand. But Mel, I'm sorry, I should probably go ahead and, because it's been a tiny bit of time, everybody probably remembers, but the base case cost effectiveness for Paxlovid, the ICERs were in the 20s, 30s, right?
Exactly right, 21,000 approximately.
Okay. Any questions? Okay, let's go ahead and vote. You guys were ahead of me on that one. Let's see the results. Okay. 8 high value and 5 intermediate. Would almost be interesting to see if it's the same 5 who are intermediate. I bet it's not, but it's intriguing. Okay, let's go to the last vote on overall long-term value for money at current pricing. Fluvoxamine, its base case cost effectiveness finding was, Mel?
8,000.
8,000 per quality or equal value life year gain. They're
Yeah,
pretty
nearly
close
the
in
same.
this case. Okay. So this one had the best, if you will, cost effectiveness in the base case model. And that's, if you can imagine, its clinical effectiveness is not as high as Paxlovid, but because of its much lower cost, its cost effectiveness came out better in the cost effectiveness way of thinking. Okay, still seeing no questions or comments. Let's go ahead and vote on this one. I think we already have. Okay. CEPAC is ahead of me. Here we've got 7 intermediate and 5 high and 1 low. Okay. Well done, Midwestern CEPAC. Thank you for helping me get through there at the end so that we can still have our break before the policy roundtable. As we always feel, we feel like we've talked about a lot about the evidence and only brushed the surface of some of the key issues around how the evidence will be interpreted and applied in the real world, how it already has been to a certain extent. But here we've got huge issues around delivery and distribution and future work around testing and et cetera. So we're going to come back to those issues when we start back at the hour, which is 2 o'clock Central and 3 o'clock Eastern. So we'll see you in about 15 minutes.